Few more minutes, please. Okay, can we start? The students, good evening, everybody. Welcome, Dr. Charles.
Thanks.
Jayanti ma'am, Kanai sir, and all other senior faculty members. And for today's discussion, we have Dr. Samir Kumar from Global. Are you there, Dr. Samir?
Yes, sir. Good evening, sir.
Good evening. And Dr. Jagdishwar from KIMS.
Yes, sir. I'm here, sir.
Okay, and Dr. Praveen from KIMS.
Yes, sir. I'm also here.
We are all there. Okay, good. Welcome to today's clinics. That is not the slide. 1 second. Are you able to see the slides?
Not as yet. Not as yet.
No.
Yeah, we can see now. Full show. Can make it as slide.
Yeah. I'm trying. Is it full screen now?
Yeah, it's full screen. Yeah, can start.
Okay, Dr. Samir, you just read out. You will be the first presenter. Jayanti ma'am, please take an active role. Today, actually, I am on standby mode.
Okay.
Because the faculty was supposed to be here to discuss today, had some difficulties. Okay. So, Dr. Charles, Dr. Jayanti ma'am, please take active role. I also chip in between. Okay.
Can I proceed, sir?
Yeah, please.
Yes. Good evening, everyone. 54-year-old male, Mr. S, college educated, businessman, informant is the patient and wife. They are known to have liver disease for the past 5 years on irregular follow-up. Now presented with pain upper abdomen for 5 days, fever for 3 days, jaundice for 3 days. Sir, further elaboration, I want to know pain. How was the onset? Then duration is 5 days. Then how, is it progressive? Then what is the site? And is there any relation with food intake? Is it associated with vomiting? Is there any radiation? And the severity also, I would like to know, sir.
Okay, so just like any other case, you will take all the details of pain. You will take the details of fever. Also, of course, jaundice is only for 3 days, so we don't have much thing to ask for it. Okay, so now when a patient with the liver cirrhosis present with acute pain, what all things should go through your mind? Then only you can ask an appropriate history.
Yes, sir. Because patient already has liver disease history, pain abdomen, generally first thing that should come to mind is spontaneous bacterial peritonitis. Then apart from that, patient can have portal vein thrombosis.
So here it is written upper abdomen, but is SBP associated with the upper abdominal pain?
No, sir, SBP is generally
what is the type of pain?
Generally, it is diffuse abdominal pain.
Oh, diffuse pain. Okay.
Yes. Then upper abdominal pain, if patient has history of alcohol intake, I would like to consider acute pancreatitis also.
Okay,
And,
pancreatitis can occur, agreed.
yes, sir. Then if he has a gallstone disease, so acute cholecystitis or
okay, so biliary pain or cholecystitis. Okay,
biliary
agree.
pain. Yes, sir.
It's in the liver.
Yes, liver, patient has any liver abscess, cholangiolytic abscess that has caused.
So secondary to cholangitis, there could be cholangitic abscess. Okay, liver abscess and pain. Anything
yes,
else?
Then luminal related like peptic ulcer disease.
No, liver not over.
Okay, liver, okay, sir.
Tumor.
Can what are the ways in which liver can produce pain? Think like that.
Yes, sir. Due to the stretching of the Glisson's capsule, that can be due to congestion.
Sudden stretch of the increase in tension inside the liver due to stretch of the capsule and fairly rapid increase in the total volume of the liver. This can happen due to
congestion that can be secondary to biliary obstruction or even due to hepatic venous
obstruction of the blood, outflow obstruction of the bile. Then
even if a large liver abscess is
large liver abscess or diffuse inflammation as in viral hepatitis. Hepatocellular carcinoma may not produce acute pain usually, but can it produce acute pain?
If there is a rupture or
is it that very common rupture?
No, sir, not very common.
Have you seen a case of rupture of hepatocellular carcinoma?
One case we had seen, sir.
Okay, that is worthy of publication, no? Okay, what happens more? Suddenly the size of the cyst increases. Bleeding into the tumor.
Okay,
that's common for most of the tumors, no? Bleeding into the tumor increases in size, all those things. Okay, so, and these are liver related. Then biliary, as you said, gallbladder and the stones producing biliary pain, biliary cholangitis, etc. Then an alcoholic person a person with alcohol use disorder can have
large liver and also
pancreatitis. They can even have gastritis. A cirrhosis patient can also have 10% to 15% may have additional peptic ulcer disease. So all these things are there. Plus there could be totally unrelated things. Okay, so related and unrelated things. And depending on each of these, when you take the first few words, when you listen to the patient, the first few sentences should give you some idea as to what type of pain it is. Dr. Charles, do you want to add anything?
Samir, when you say fever, jaundice, and upper abdominal pain,
yes, sir.
So what are the things that comes to your mind?
This is actually looking like a Charcot striate, but it is in the upper abdomen, not right hypochondrium they specified. So I would like to consider cholangitis also in this patient, apart from liver abscess. And because history of liver disease is there, one remote possibility of spontaneous bacterial peritonitis also I would consider, though it is not diffuse pain. Right-sided empyema is also one possibility in which they can have right-sided pain sometimes in the right hypochondrium.
Can it be acute alcoholic hepatitis?
Yes, duration, though it is 3 days, acute alcoholic hepatitis can also have present with fever, jaundice, and abdominal pain. Low-grade fever can be there.
Ma'am, do you want to add anything?
Fine, I think, yeah. So I think plasma, just keep on, infection, inflammation, vascular, neoplastic, miscellaneous. Just keep that in that category. You will come out with some of the differentials automatically.
Okay, now you please go through it.
He was a known case of cirrhosis of the liver diagnosed 5 years ago, was on irregular follow-up and treatment, recently presented to emergency with upper abdominal pain for 5 days. Acute in onset, felt in the epigastrium, severe in type, for which he took oral painkillers initially. There is no radiation of back, shoulder region or scapular region. Pain became less with medication, but worsened after 2 days, which forced him to attend emergency. He developed moderate fever 2 days after the onset of pain. There was no chills or rigors. Fever was present throughout the day and night. He also noticed worsening of pre-existing mild jaundice 2 days after onset of pain. No history of pruritus. He vomited a few times at the height of pain, and vomitus contained small quantity of partially digested food. No GI bleeding during the current illness. No altered sensorium on presentation to hospital.
Okay. Are you happy with this history, or do you want any additional things?
No aggravating, no relevant factor. Yes, sir, it is. I'm okay.
It was fairly acute in onset of pain. There was no aggravating factor, and the relief was obtained by taking oral painkillers. And after 2 days, it became again worse, and then he had to go to the hospital to take injection. So these are the aggravating and relieving factors. Okay. Apart from
what
that,
happens is if a person has a liver abscess, they'll have a catch on deep inspiration. That will give you a clue. So they will withhold their breath. Likewise, if there's an acute polycystitis, say with Murphy sign positive, the respiration will be guarded. So, you can almost get that information in the history that when they cough or they sneeze, then it can be an acute pain.
okay, or rather the inspiratory catch.
Yeah, inspiration.
Okay, so Dr. Charles, would you like to?
No, sir, nothing.
Okay.
Past events, he developed hematemesis followed by melena 5 years ago when he was diagnosed to have cirrhosis related to alcohol use. He had endoscopic therapy with bands for 3 times at intervals of few weeks. He was asked to stop alcohol, which he did for the next 2 years. There was recidivism after 2 years for next 6 months when he developed GI bleed again. Endotherapy was repeated. For the last 3 years, he does not use alcohol, but reports to hospital only if there was any health problem. He had GI bleed 9 months and 3 months ago, and he noticed pedal edema, abdominal distension after each episode of bleed. He was admitted in the hospital for about 1 week each. Endoscopy was done, but no banding was done. He was on medication since then. Edema subsided in 2 weeks' time. Past illness, he has diabetes for last 7 years on OHA, poor control. There was no abdominal pain in the past, no history of any altered sensorium after GI bleed, no past history of any jaundice or liver disease prior to 5 years. Family history, there is no relevant history. Personal history, feels feverish, appetite is reduced for last 1 week, bowels are constipated for last 5 days. History of alcohol use disorder from the age of 28 years until 48 years of age. He used to take 3 to 4 units 2 to 3 times per week. We started drinking at the age of 50 years and continued for next 6 months. He has not taken alcohol for the last 1.5 years. No smoking, no other high-risk behavior. He is middle class socioeconomic status. His diet requirement is 1600 kilocalorie, intake about 1200 kilocalorie, and ECOG performance status is 3.
Okay, can you summarize? Do you want any further details?
No, sir. So there was no associated abdominal distension at any time. Even
abdominal distension. That I don't think was any. He didn't complain of abdominal distension. There was only pedal edema, I think.
Okay.
Output was normal. Urine output. Urine output was normal.
Oh, recently there was no change in the urine output. He has noticed actually abdominal distension when he had GI bleed 9 months ago and 3 months ago. No, at that time there was a pedal edema and abdominal distension, which I think disappeared within 1 or 2 weeks of treatment. That's the history. At the moment he has no. At the moment he has no reduced urine output. He has no abdominal distension. Okay. So that's the history. Total history. You have to build up your diagnosis on basis of the entire history.
Okay, sir. So this is a 50-year-old male who was diagnosed to have chronic liver disease 5 years back, alcohol use disorder related chronic liver disease. His index presentation was upper GI bleed, following which he was abstinent for a few months. Later, he had recurrent episodes of GI bleed, following which he remained abstinent till the age of 48 years. But now again, he started taking.
Summarize, Sameer, don't
okay, ma'am.
You're summarizing one case of alcohol
chronic liver disease. Was had recurrent episodes of GI bleed in the past, associated with abdominal distension and edema during the times of GI bleed, which have been controlled with endoscopy and banding. He is also known case of diabetes for last 7 years on OHA.
Just hold on. Just finish up all the complications. Compensated. He's otherwise compensated.
He's otherwise compensated.
No urinary, no renal dysfunction. Finish up all the complications. No?
Yes, ma'am.
And the recent history of fever, jaundice, and
abdominal pain.
Yeah, that's basically what you want to disclose is cirrhosis, its complications. Come out with that in your summary. And then the bleed you have to discuss whether, because they said no banding was done, so whether that bleed was related or unrelated. That we discuss, that will come in your summary, and with the recent history of abdominal pain, fever, and jaundice. Yeah, Dr. Charles, we would like you to take over because you are the liver team, liver hepatologist.
Yes, thank you. Thank you, ma'am. Samir, what would be a differential diagnosis here? You got a cirrhotic patient who had bleeds before, no banding, now presenting fever, jaundice, and upper abdominal pain. What would be a diagnosis that you consider here?
Still, the differential I would consider is features. There's no abdominal distinction. A liver abscess, a possibility I would consider, sir. Cholangiolytic abscess. If also acute cholecystitis is also a possibility I would like to consider. And
why you want to consider something different from cirrhosis? Why don't you? If patient has got cirrhosis, he had decompensation before.
Related to cirrhosis, unrelated to
now
cirrhosis.
again decompensation with jaundice.
Yes.
So
related to cirrhosis, patient has yes, sir. If related to cirrhosis, first possibility I would consider is spontaneous bacterial peritonitis, then portal vein thrombosis,
acute portal vein thrombosis,
acute portal vein thrombosis, and
is it common to have fever in acute portal vein thrombosis?
Sir, if it is significant portal vein thrombosis, if ischemia of the bowel is there, then patient can have fever, and the fever can be there. Or large area of necrosis is developed in liver also, they can develop because of decreased blood supply. Patient can, the liver can go into necrosis and can develop fever. And also secondary infections can develop due to translocation, because portal vein thrombosis occurs and translocation of the gut bacteria occurs, and patient can develop sepsis in that case.
And then the other definitions would be?
Yes, sir.
He has restarted alcohol. Would you like to consider?
Alcoholic. Oh, okay. Alcoholic. Last one. Yes, alcoholic hepatitis is also one possibility. Alcoholic hepatitis. Acute and chronic liver failure I would consider, because already is a chronic liver disease.
Could it be a mass? Could it be hepatocellular carcinoma?
Presenting with acute pain, a remote possibility I would consider. Hepatocellular carcinoma. There is no history of weight loss or loss of appetite. Only for.
When you say remote possibility, no?
It is a possibility.
It is a possibility, no? It is a long-standing history. We do not know whether it's hepatitis B. We do not know whether he's got an underlying C. We have no idea. No, we only know that he's got alcohol-related liver disease. But HCC is a differential. What are the manifestations of HCC in a cirrhotic liver? How can they present?
They can present with lump abdomen, pain, right hypochondria, loss of weight, loss of appetite.
Number one, they present as PO.
PO, yes, ma'am.
That is number one. Number two, they can present as paraneoplastic.
Paraneoplastic, like hypercalcemia, hypoglycemia.
Number two. Number three,
but here is
1 minute. Cirrhotic livers can suddenly become enlarged. That's number three. So when you find a cirrhotic liver and it's palpable, then you start suspecting a HCC. Number four is presenting like an acute Budd-Chiari syndrome, either by infiltration or by extrinsic compression. Okay? And in a patient like this, when a person has sudden onset of ascites, or a person has a sudden onset of abdominal pain, just like Dr. Ballis mentioned that, no, you can have a necrosis, you can have a bleed with it, and the patient can have an acute pain, and nothing prevents him from having a hematuria, and you can have still pharyngitis. So one possibility is you have to, it's not, in an acute onset like this, you will not have loss of weight and appetite. It will not be there. So these are the manifestations of HCC in a cirrhotic liver. Okay, do you think the patient's got cirrhosis of the liver? Why do you say he's got cirrhosis of the liver?
Sir, ma'am, upper GI bleed is there.
How do you know? That only tells you he's got portal hypertension?
And yes, ma'am, only portal hypertension is there.
What in the history tells you that he's got cirrhosis? There's nothing. The transient decompensation will be just part of the ischemia, transient hypertension and partial, and then he decompensates and decompensates again. Dr. Charles, would you agree to that? That what in the history will tell you that he's got cirrhotic liver? That's what I'm asking.
Nothing, ma'am, except that they said that the fastest way has the patient has diagnosed with cirrhosis 5 years back.
So we only have an information that someone has told he's got cirrhosis of the liver. Otherwise, it may be hepatitis B, virus infection, and alcohol may just be a bystander and the whole thing of losing your track on the alcohol. And the patient may just be having a liver with HCC. And family history, you cannot say he's got cirrhosis. It's only based on the historical past. If he's well educated, yes. And do you think this is a natural history of 5 years? Do you think this is a natural history of cirrhotic liver?
No.
What will be the natural history? Someone says I've got 5 years. He's been drinking from the age of 28. Okay?
No, yes.
And I know there's cirrhosis 5 years. What will be the natural history as we go along?
By this time, we should have developed edema of feet, so abdominal distension.
What will be the rate? Say what will happen at 3 years? What will happen at 5 years?
Ma'am, every compensated, yes, ma'am, 10% patients every year.
Questions that you've asked. Yeah. 10.
Ma'am, 10% of every patient who are compensated will go into decompensation every year, and especially if alcohol abuse is going on, the percentage will increase to almost 30 to 40% every year.
So, it will be the natural history of a cirrhotic liver as well. So keep your mind open. Someone has cirrhosis, but keep it okay. Doctor has made a diagnosis, and just check out which hospital you went to. Is a tertiary medical center. Then the likelihood of a cirrhosis liver is likely. But if he's just being with a family physician who's managing him, the possibility it may be cirrhotic, it may be non-cirrhotic. Dr. Charles, you can just please ask some clinical questions. The whole discussion will hang on just around this. You can ask some more questions here. It would be nice if we can just push in some more questions.
Yeah. What are the other differential diagnoses you'd like to consider? If you think that he is not a cirrhotic or he just has a chronic hepatitis B or C.
Sir, not a cirrhotic.
Pain.
Yes, sir. Alcohol use disorder, hepatitis also is a possibility if patient is not a cirrhotic. Then hepatitis B reactivation that can present with history of fever, jaundice also. And though he's a male patient, autoimmune hepatitis can be also considered in this patient. And
it's got fever, jaundice, and upper abdominal pain.
Possibly Wilson's disease, and he's developed hemolytic anemia, and he has stone disease. Presenting this, is it possible?
Yes, ma'am. 54 years also, greater than 40 years also, 10% of the cases can present.
Oh yes, can present at a later age.
Yes,
is it possible that it is reported biliary cholangiopathy, and he's got actually an EHPDO, and now he's presented with cholangiopathy? All these should come in your mind, because whatever the patient has, as far as the history is concerned, there's only a transient decompensation, which is not fitting actually with the natural history of the cirrhotic liver, and that too consuming alcohol for this period. So always keep, when you discuss this case, you have to discuss this, like you say, it is chronic liver disease. I think that we can agree to that. And the only thing is that there is chronic, but I would definitely consider there are 2 episodes of bleed. The whole thing is just in EHPA, which doesn't biliary cholangiopathy. That's one possibility. Number 2, I would consider whether it's Wilson's disease, chronic liver disease, hemolytic anemia, stone disease, and he's got cholangitis. And if you accept the diagnosis of cirrhosis, in that context, cirrhosis of the liver, it's not fitting in 5 years by now, we're expecting some decompensation. There was cirrhosis of the liver since he has been absent for quite some time. Then you consider the possibility of you can get stone disease, and you can get a liver abscess as well, and HCC, Okay, and also keep all the differentiations, biliary ascariasis, all these intraluminal causes which can present as cholangitis. You'll be in for a surprise when you find that the biliary system is dilated and there are a lot of ascaris burns. Understand? Can it be hydrated? Can it be hydrated? I do not know the case. That's why I'm just discussing all the possibilities. So when the Pandora's box opens, nothing is left out. Can it be hydrated?
Yes, ma'am. Hydrated is a biliary stricture.
Cirrhosis liver. And how will it present with fever, chills and rigors and jaundice?
If there is a communication with the biliary tract, patient can have cholangitis. And
other question you should ask is any endoscopic intervention has taken place. I think that's important. Okay, you can move on. Don't forget the intervention.
Yes.
So at the end of the discussion, Dr. Samir, what would you like? Where do you want to put your money on? What is the diagnosis? Is there cirrhosis? So this is a case wherein the patient says that I was diagnosed to have cirrhosis of liver or perhaps some disease of the liver. Okay. And until and unless you have got a record which definitely says it is cirrhosis, probably this is like a tip which will take you to the wrong direction. So just because you got the diagnosis of cirrhosis, it may actually blunt your thinking process.
Okay.
Is there any way you can explain? This chap was drinking 2-3 packs, and then over a period of time he increased, and then when he developed problem he stopped, and there was obviously nothing to suggest alcohol hepatitis. Then he stopped for about I think 2 years, and during that period the only problem was he had one episode of GA bleed. It was treated by some endotherapy according to you. And then after some time, when he was all right, he again started drinking. That's the time when he developed 2-3 episodes of bleed. And those time, the endotherapy was not done. According to him, only endoscopy was done because he is aware that some banding was done earlier. What do you think then?
So whether it is unrelated to portal hypertension like a peptic ulcer disease bleed, or related to portal hypertension can be portal hypertensive gastropathy or GAVE.
Will that produce a significant bleed to produce decompensation? What could be the cause of so-called ascites, and he has abdominal distension and pedal edema? So how do you explain that? And he had no encephalopathy during that time. How do you explain that?
Sir, in these bouts of GA bleed, a patient tends to have a transient increase in portal hypertension, and they will sometimes have transient appearance of ascites and pedal edema also, which later becomes reversible. This is especially seen in those with NCPIH or extrahepatic portal vein obstruction.
Okay, especially, okay, it can develop due to the bleed itself, or it can also develop occur due to over-enthusiastic administration of crystalloids also. Okay, that is another situation. Okay, because of the bleed, the first hospital started normally, and the second hospital continues it, and probably over 24 hours or many days it will continue. People may not notice it, and such a thing also may occur. So that can happen in non-cirrhotic portal hypertension as well. Okay. So in the end, where do you want to put your money on?
Sir, definitely diagnosis is portal hypertension. Then I would like to look at the etiology. First is cirrhosis of liver, that is alcohol use disorder related, or hepatitis B related, and other like Wilson's and chronic bacteria. Apart from that, portal hypertension secondary to extrahepatic portal vein obstruction or non-cirrhotic portal hypertension. These two things I will consider, and the complicated now if VHPVO with portal cavernous cholangiopathy.
Between the two, your bet will be non-cirrhotic portal fibrosis vis-a-vis VHPVO or cirrhosis. Between the two. Based on the natural history, it fits more as NCPF or CTPA score, CTPA cirrhosis, or it will be NCPF or EHPVO. My bet will be it will not be a full florid cirrhosis. If at all, cirrhosis, CTPA.
CTPA.
Do you consider alcoholic hepatitis?
Yes, sir. Yes, sir. That was covered, sir. Another third possibility is alcohol use disorder hepatitis.
Okay, but for the last 1.5 years, he is not drinking. So what is the usual cutoff period between the last drink and alcoholic hepatitis?
Sir, within the last 6 months, at least he should have had one drink.
So he was not drinking for the last 1.5 years. So will it fit in with the diagnosis? Of course, there are situations where patient will tell lies to us. So we have to keep your mind open. Okay, in a person with alcohol use disorder, there is always a possibility that he may be underrating his drinking quantity, as well as he may also tell that he is not drinking and may be continuing to drink. Okay, shall we move to physical findings?
Sir, on general examination, his weight is 78 kilograms. BMI is 25.6. Corrected BMI is 23. Okay, sir. Pulse is 102 per minute. Blood pressure is 140 by 80 millimeter mercury. He is febrile. Temperature is 101 degrees Fahrenheit. Icterus is present. Spider nevus present over chest and back. Bilateral gynecomastia present. Jugular venous pressure is not elevated. No palmar erythema. Here I would also look for hepatojugular effect. No palmar erythema. Dupuytren's contracture is present. Bilateral pitting edema of legs. Frailty test could not be performed as patient was confined to bed. As performance status was 3. On systemic examination, abdomen inspection, abdomen moderately distended. Umbilicus is central. No umbilical hernia. No dilated veins in front or back. All quadrants move equally with respiration. palpation, liver is palpable 2 centimeters below the right costal margin and 7 centimeters in the epigastrium. Firm, irregular surface, mild tenderness on deep palpation, spleen is not palpable, hepatojugular reflex is absent. Flanks are dull and shifting dullness is present. Auscultation, no bruit or hum, and cardiovascular system and respiratory system is normal. CNS, no flapping tremors present. Number connection test is positive. His sensations normal, knee jerk, ankle jerks are diminished. This is probably due to alcohol-related neuropathy or diabetic neuropathy. He's a diabetic.
Okay. Now you tell your diagnosis.
Sir, now it is now I would consider cirrhosis of portal hypertension, secondary to cirrhosis of liver, alcohol use disorder, being the etiology. Now complicated with fluid overload, jaundice, fluid overload in the form of ascites and swelling of feet, jaundice, and suspected hepatoma in this patient, hepatocellular carcinoma in this patient.
So he has got some signs of chronic liver disease. He has got evidence of fluid retention, and we don't have much. Liver is just palpable, that's all, and deep tenderness. Okay.
Samir, what in the findings tells you he's got portal hypertension?
Only spider nevi is.
No, spider nevi. What does it indicate?
Alcohol.
What are signs of portal hypertension you look for?
Sir, here basically one is ascites is there that suggests portal hypertension. Splenomegaly, spleen is not palpable.
And veins. So
no
veins are there to be portal hypertension. Spleen is not palpable. The veins are absent. There's only minimal fluid. So what tells you that this patient actually has got portal hypertension?
In history only.
No.
Examination.
History also we said, no? May not be
yes.
Be very careful in the exam. This particular patient, now you said he has portal hypertension, then you're taking off. It's not that. What he has is an irregular surface liver indicating there is cirrhosis.
Cirrhosis. Okay.
Okay. Most of the cirrhotics will have portal hypertension. We agree to that. But findings are there, not there to say it's got portal hypertension. Okay? But to Charles, you can just take over this.
Samir, after examination, what would be your differentials here?
Sir, cirrhosis of liver, then secondary to alcohol use disorder. Now that is decompensated in the form of fluid overload, ascites, and edema, along with GI bleed in the past, jaundice also now. Liver differential enlargement is there, more in the epigastrium. So, hepatocellular carcinoma also a possibility I would consider. Then another possibility is alcohol use disorder related hepatitis, in which also patient can have transient portal hypertension leading to ascites, edema, and also palpable liver.
Then so you got a cirrhotic who is decompensated with ascites, jaundice, and recent onset fever. So what would be a 1, 2, 3, 4 differentials?
Now complicated, probably with spontaneous bacterial peritonitis.
One could be spontaneous bacterial peritonitis. What are the points against SBP here?
Fever against SBP. Pain is not diffuse.
Pain is not characteristic. You are not finding any diffuse tenderness or
not diffuse.
The abdomen. And
but 10 to 20% of patients with SBP also can be like vague pain and sometimes symptom.
Yeah, still it could be SBP. One, then second diagnosis.
Then portal vein thrombosis also I would consider in this patient because there is sudden worsening of jaundice and ascites. Then
how often you get acute onset of that severe pain requiring injections in portal vein thrombosis?
No, sir.
Actually, abdominal pain is not a dominant picture, though it can occur. But the mesenteric vein thrombosis is one. When portal vein thrombosis extends to mesenteric vein, then you can have pain because of the mesenteric ischemia. But pure portal vein thrombosis may not have that significant pain. Okay, portal vein thrombosis may present with the exacerbation of ascites or a new onset of ascites. Mesenteric vein thrombosis can present with the severe abdominal pain, ascites. One of the picture will be SB, it may not be SPP, but peritonitis due to ischemia, and they may even present with the diarrhea also. Okay, these things can be there in addition. Okay, so severe pain in a pure portal vein thrombosis will be difficult to explain.
Your comment on HDR being absent?
Two possibilities. One is that patient is developing sinusoidal obstruction or cirrhotic cardiomyopathy.
Cirrhotic cardiomyopathy? Come on. When all can you get an absent HDR?
When there is fluid, either the outflow tract is obstructed.
Yeah, outflow tract. Can you get an alcohol-related liver disease?
Yes, ma'am. Yes, ma'am. Because there is central venulitis, so that is a
central hyaline sclerosis will present just like veno-occlusive disease, sinusoidal obstruction syndrome. That can explain everything now. You've got a liver, you've got an ascites, he's got a tender, maybe an acute onset, maybe he's got a prothrombotic state, he's got hepatic vein outflow tract obstruction. His HDR is absent.
Yes, ma'am. Liver is carpal tenderness.
Okay. One of the cause of acute pain, NBK always tells, oh, it's acute.
Yes, ma'am. Yes, ma'am.
Shall we proceed?
Shortlisting, what's your diagnosis?
Ma'am, cirrhosis of liver, secondary to alcohol use disorder, that is now either complicated by decomposition in the form of ascites, jaundice, ascites, probably spontaneous bacterial peritonitis, also the consideration of Budd-Chiari syndrome and or sinusoidal obstruction syndrome.
Be very careful when you're using these terms. You're using all these terms interchangeably. Have a very clear concept. What is veno-occlusive? What is sinusoidal obstruction? What is outflow tract obstruction? Have a very clear concept. They're all not synonymous.
Yes, ma'am.
Okay.
Okay, so when this case was written by the SR and shown to me, and subsequently did not fit with the clinical diagnosis, I went and cross-checked hepatojugular reflux. It was actually normally seen. The resident did not know how to do it properly. So please, will you please tell us how do you do hepatojugular reflux?
Sir, we have to give pressure with the palm over the right hypochondrium for 15 to 20 seconds and see if there is elevation.
Is it so much that you keep it in the right hypochondrium?
No, sir.
It is otherwise known as
abdominal.
So it can be kept in the epigastrium as well, no?
Yes, sir.
Okay, how long you keep it?
So 15 to 20 seconds.
So I knew that this is positive, but it was written like this by the resident. So sometimes there will be a disparity between what is shown by the what is told by the candidates for examination and what is seen by the examiners. And in such situation, you will be asked to go and examine. Sometimes they will ask you to demonstrate also. So you must be very clear in your mind as to how you do it. There should not be any doubt. So this patient actually did not have a negative hepatojugular reflux on subsequent evaluation. Okay. So how will you now evaluate?
Sir, first the baseline investigation of complete blood count with the liver biochemical test, prothrombin time and INR ratio. And
he'll fall. That whole thing will fall down. No? It can't bear so much weight. In third ram, battery within
Samir, I inadvertently muted you. So please unmute.
Yes, sir. Sir, okay. Complete blood count with PTINR, liver biochemical test, renal function test, and the fever is there, so a blood culture and ascitic fluid tapping with sending it for.
Tell you what, in the exam, when you answer such a question, please just keep it's not, you just don't list it out. You say I'll do a complete hemogram to look for a bicyclic or a low platelet count that will help you in my diagnosis. I'll ask for a peripheral smear, which will tell me whether the patient has got macrocytic or microcytic anemia. I look into the indices. Please speak in that manner in exam.
Okay, ma'am.
Don't just say, even when we ask you for the list, please tell why you're asking for the list. Then they will tell you the results. Then they will
Okay.
follow the results. Don't just say, I'll take blood culture. You just tell, I'll take all precautions to do a proper blood culture. We'll be a bedside culture at 2 different sites and take the sample at the bedside. All this you must tell. Speak in that manner. If it's going to be a live session and not the virtual, all these things will be taken into account when you're presenting.
Okay. In complete blood count, I'll see hemoglobin, then MCV, whether it is microcytic or macrocytic anemia, along with the total count.
Reports are there. 11.4. There's a WBC.
Total count is elevated, ma'am. 40,250.
Count is 77,000. Yeah.
Yes, my platelet count is reduced. ESR is 56. CRP is 21. Creatinine is 1.8. Blood urine nitrogen is 87.
Comment on the blood sugar.
Ma'am, blood sugar is elevated. He's already diabetic, so it's very poorly controlled. And the creatinine is also elevated. I would like to know the baseline. Even though baseline is not available, this is definitely acute kidney injury. B1 is also elevated. So possibility here is a pre-renal IKI. Then in liver biochemical test, total bilirubin is 14.1. I was expecting conjugated bilirubin, and total direct bilirubin is 7.1. So almost greater than 50%. AST/ALT in the range of 121 by 142, but I expected AST to be higher than ALT. Here it is reverse. In the range of hepatocellular jaundice. Alkaline phosphatase is also mildly elevated, 231. I would also look for albumin, which is 2.9, and globulin is 3.6. So there is age reversal, which I was expecting this patient for cirrhosis. MLS is 186 and lipase is 241, which are
both are elevated. Yeah.
Elevated, yes, sir. 3 elevated, sir. And INR is 2.1, so it is also elevated. Sodium 132, potassium 4.9. So he is having coagulopathy, leukocytosis with acute kidney injury and conjugated hyperbilirubinemia, which is both hepatocellular and obstructive in nature.
So from this picture, what all you think he has got? He has got, I think, abnormality in every sentence. Okay, so tell us what it is.
Sir, so these duration of symptoms are occurring less than 4 weeks, and he's got INR more than 1.5, bilirubin is greater than 5. So this is like an acute chronic liver failure syndrome.
Also acute what? Acute. Make it very clear. What?
Acute
what was
chronic,
it?
Sir, acute and chronic liver failure.
You think it is ACLF?
Yes, sir.
Okay. Does he satisfy any of the characteristic of ALF?
ALF,
acute
no,
liver
sir,
failure.
Because already he is having a history of compensated cirrhosis in the past.
Okay, so there is a history of cirrhosis in the past, probably as per the patient story.
Sure.
Okay.
And also encephalopathy, though his NCT is positive, yes.
Okay, what level of encephalopathy you require in ACLF? Is it a minimal hepatic encephalopathy confirmed by NCT?
No, sir, overt is generally, we are
patient does not have overt encephalopathy, no?
Yes, sir.
Okay, so
that is against ALF again, encephalopathy is not there. And ascites generally will not be in ALF, though it can be present in subacute hepatic failure. So that is again supportive of ACLF.
Samir, what is the definition of ACLF?
Sir, as per APASL criteria, increase in bilirubin greater than 5, along with INR greater than 1.5 or less than 40% prothrombin activity, complicated within 4 weeks by ascites and or hepatic encephalopathy. That is associated with high 28-day mortality. Whereas ESL, there is organ failure involvement. In ESL, here this patient is having bilirubin greater than 14. So one organ is there, and creatinine is 1.8. Though it has to be 2, but INR is greater than 2, sir. So 2 organ failures are there here also. So that will also qualify as per ACLF.
And you made the comment of acute kidney injury. What made you say it's acute kidney injury? You don't have a previous creatinine level.
Sir,
if he's a diabetic, long-standing diabetic.
Yes, sir. Long-standing diabetic, he can have underlying diabetic nephropathy and chronic kidney disease. I would ask if any baseline creatinine is available within last 3 months. If 1 week, within last week, 1 week will be better.
And what's the definition of acute kidney injury?
Sir, acute kidney injury, KDIGO definition is increasing greater than 0.3 milligram per deciliter over the baseline, or 50% increase over 7 days, or you not put less than 0.6.
We don't have a baseline here. So
baseline
when you say okay.
Baseline is not.
Is it an acute liver injury?
Acute liver injury, yes, ma'am. So ascites generally.
Oh, but when do you say it's acute liver injury?
If there is a jaundice and coagulopathy, not
ALI versus ALF. What's the difference between ALI and ALF?
encephalopathy will be component of acute liver failure now.
So in acute liver injury, you have an INR prolongation. If NTP sets in, then it becomes an ALF.
Yeah.
Samir, would you consider acute liver failure here?
No, sir.
No.
Acute.
Why? Patient has features of chronic liver disease. Patient has got gynecomastia, patient has got spider nevi, patient has he has got features of chronic liver disease. So you except three. What are the conditions that you can have when you diagnose ALF? Like, patient is the chronic D flare.
Yes,
but and Wilson's. So these things, even if there is underlying chronic liver disease, when there's acute decompensation, you can consider as ALF. Otherwise, you didn't consider acute liver failure here because it has got evidence of chronic liver disease.
Okay.
I think that point by Dr. Charles is very important. That question is often asked. When can you have a deviation of an ACLF definition? So one is, even though they have an underlying liver disease for acute Budd-Chiari as well as for Wilson's disease, you still call it as an ALF. And I think in some of the books, they also mentioned alcoholic hepatitis. Even if they have an alcohol-associated hepatitis, when it presents as an acute severe alcoholic hepatitis, even though they have an underlying liver disease, they still call it as three situations where Acharya and others have mentioned these three conditions, where even though there's an underlying liver disease, it's still called as an acute liver failure. And they present like an ALF. Okay, any other investigations you want?
Ma'am, ascitic fluid, I would also send blood culture, paired blood culture and ascitic fluid analysis, along with that ultrasound abdomen and an upper GI endoscopy.
Doppler. Always ask.
Yes, upper GI Doppler. Yes. Ultrasound abdomen, liver, both lobes nodular, coarse diffusely, no focal lesions. Minimal central IHBRD noted in both lobes. CSD is 9 mm, CBD is 10 mm. No definite stone is seen in CBD. Pancreatic duct is normal. Gallbladder is mildly distended, wall thickened, multiple stones seen. Pancreas head is mildly bulky, body normal, tail not visualized. Moderate ascites, spleen, moderate enlargement. So he's having an underlying gallstone disease as well, for which he has developed acute cholangitis, and probably obstructive jaundice secondary to acute cholangitis. His pancreas head, sir, Doppler.
Samir, just interpret the results.
Yes, sir. And there is gallbladder wall is mildly distended also, and wall thickened. Greater than 4 mm.
Ultrasound shows cirrhosis liver.
Yes, sir.
Okay. And there's a portal hypertension.
Yes, sir.
He's got a splenomegaly. He's got ascites. And you're seeing multiple gallstones.
Okay. No. So he's having chronic liver disease with ascites and also gallstone disease, causing IHBRD with choledocholithiasis as well. And head of pancreas. Sir, CBD and CSD are dilated. Probably it is at the distal
CBD.
Sir, his age is 5. His age is 50 years, so around 6 mm, 6 to 7 mm. I would expect for this question.
NMM is dilated, no? It is not a post-polycystic.
Not yes, ma'am. Not post-polycystic.
1 centimeter almost. You think it's a choledochal cyst?
Choledochal cyst is a possibility, ma'am.
Just because I'm asking, don't say that.
Yes. But even at this age, and it can be a possibility.
The fusiform dilatation is still called 1 centimeter is quite a large one, no? And yes, they've not picked up the stone. The possibility is there could still be a stone impacted at the distal CBD.
Distal CBD.
Because amylase was transiently elevated. Lipase was also 746, I think.
Yes, ma'am. 240.
Yeah. Likewise was slightly high, I think.
Yes, ma'am. And this pancreas rate is mildly bulky, so probably he's also having alcoholic pancreatitis, which is in the form of chronic pancreatitis, though no calcifications or PD dilatation is there. So this
Samir,
bulky head of
we want to go look for a second cause for pancreatitis.
sir,
You are saying that he's got gallstone disease. You are saying cholelithiasis. Then why you want to bring in alcoholic pancreatitis?
yes, sir, gallstone pancreatitis only first possibility.
That would be the first possibility.
Yes, gallstone pancreatitis.
Percentage of patients will have combined cirrhosis and pancreatitis.
5 to 10% of the thing.
Oh, less than 5%. Kerala study as well as our own study showed 2 to 5% will have a combined cirrhotic liver and pancreatitis. So that itself is uncommon. So therefore,
one is predicted to others.
So common, just bring in the common things. No, why
Yes,
you bring in one? This is where you people have problem. How can you just bring in another alcohol-related pancreatitis? No, it's not presentation pancreatitis. So what else you want now next?
Here, Doppler also like to see, ma'am, with the portal vein diameter flow and the splenic vein diameter flow.
What else?
And hepatic veins also, whether they're patent or not.
Listing, just keep listing, then we'll show you results.
Yes, ma'am. And after the next investigation, upper GI endoscopy, ascitic fluid tapping, and also upper GI endoscopy.
And viral markers.
Viral markers. Yes.
Viral markers.
Ascitic fluid, I think ascitic fluid was done.
Yes.
I think ascitic fluid showed evidence of SPP also. It was also okay.
Sir, so blood culture is showing the Klebsiella species. This is probably secondary to acute cholangitis, and here I think the gallstone disease is the precipitating factor for ACLF. Antibiotics is on meropenem. INR is 2.1. Injection vitamin FFP given. INR improved to 1.8. Creatinine worsened from 1.5 to 1.8 over 2 days. 2 days. B1 increased to 86. He was started on IV albumin and terlipressin was also given. He was well hydrated, and on Thursday creatinine dropped to 1.5. Decided to do ERCP. So because of acute cholangitis,
this was the MRCP. This was the MRCP.
Okay. Dilated CBD and CSD. Stone in the lower end of CBD measuring 6 mm. Mild dilatation of central IHBR. GB showed multiple stones. MRI showed bulky head region of pancreas. No mass and pancreatic duct was normal.
Samir, if you go back to the ultrasound, from there, if you can pick it, what are the further investigation you need from there?
Sir, actually, this patient is in acute cholangitis and distal CBD is obscure. So we can do an upper GI endoscopy followed by EUS at the same setting and see if there is a distal CBD stone. So we can go ahead with, once the patient is stable, we can go ahead with an ERCP procedure as well. Or MRCP also we can do, sir. And
what is the problem with MRCP here?
ascites is there, so fluid is a little bit difficult.
We may not that. Okay, and he's got a creatinine of 1.5, 1.8.
Yes, sir. So CCT abdomen is
may not be possible.
Yes, sir.
So
and distal lesion better can be visualized with sir.
If you have if you have EUS with you, then that would be the first investigation.
Yes, sir. Okay. Then so blood culture already we have got Klebsiella. So as per that sensitivity if available, we can continue. Then other.
How will you manage this patient now? He's got gallstones. He's got CBD stone.
Yes, ma'am. First.
Blood culture positive. So just list the management 1, 2, 3, 4. What would you write and how would you manage this patient? Okay,
just go through this. Side wing scopy showed pus pouring from the ampulla. Sphincterotomy done. Housing control of the, of course, saturation was unstable. Only a pigtail was introduced, and then pus culture, which was subsequently shown E. coli. I think it was sensitive to higher end antibiotics only.
Okay, sir.
Okay, what you will do?
Sir, first stabilize the patient, starting with antibiotics and monitor hemodynamics. Then, apart from antibiotic, will also give albumin for this patient because it has both anti-inflammatory activity also, and he has got an AKI. So for AKI albumin, if this is AKI stage 1A, then albumin alone. If it is more than that, 1B, I would start terlipressin as well. This patient, terlipressin, albumin both were given. And if patient is not at all stable, then as per the Tokyo guideline, we have to do an urgent ERCP and at least do stenting, if not stone extraction. So this patient was stable after antibiotic. This creatinine and other parameters like bilirubin show a little bit improvement. We can take him for an elective endoscopy within the same admission, elective ERCP in the same admission. But one thing, blood culture being Klebsiella means that patient has severe sepsis. So ERCP has to be done at an early stage, which has been done. And for acute kidney injury, on monitoring, we have seen that is initially creatinine had improved to 1.5 following fluid restriction, but here it is again worsening. So if terlipressin was being given, I would like to increase the dose of terlipressin first and monitor the urine output, and also do a blood gas analysis to see if there is any metabolic acidosis. If there is any worsening of acidosis or patient is oliguric or anuric and still creatinine is increasing, then a renal replacement therapy would be needed in this patient. And apart from that, supportive management in the form of nutrition and
What do you do with the gallbladder stone?
yes, ma'am. Gallbladder.
How do you manage the gallstone disease?
Gallstone disease at present only stenting can be done because it's a high risk candidate for any surgery or intervention at present.
Manage the gallstone.
Will you do anything in the future?
Future, so once he is stable, a patient definitely has to undergo a surgery, both the stone extraction as well as cholecystectomy.
What type of polycystectomy?
Cholecystectomy, sir.
Patient has got ACLF, right?
No, sir. ACLF at present, cholecystectomy now is not.
Not now. Patient has got ACLF, right?
Sir, because of the precipitating factor is gallstone disease. Sir.
He's got acute and chronic liver disease secondary to gallstone disease. He's got a biliary pancreatitis. SBP. He has got hepatorenal syndrome and sepsis in the form with Klebsiella and E. coli in the blood.
Yes, sir.
Right. So now after you have managed, how will you reassess him?
Sir, once his fever counts have settled down, his creatinine is, if it is improved, his bilirubin has come down, and his ascites also has reduced. So that, then again, I would like to reassess the patient, what his status is. Generally, these patients who are on acute and chronic liver failure will have a progressive disease in future, and even in later term, if we want to plan a cholecystectomy, he will be a high risk case. So I would stratify him whether it's CTP A, CTP B, or CTP C after recovery of this. Mostly he will be in CTP C. So conservative management with periodic exchange of stents will be an option for this patient. If a liver transplant is planned, then with that we can remove.
Why if? Why do you say if?
Sir, if alcohol, his liver transplant will be an option.
Yes. When would you consider cholecystectomy? When would you consider liver transplant? Suppose he recovers and his level is below 15. He is child A or early B. In such situations, you might do a cholecystectomy.
Yes, sir.
Otherwise, you have to consider liver transplant here. There's no if or but there. So.
And in these patients, always plan for a partial cholecystectomy. Never touch the gallbladder in its bed, because they'll all be tethered to the liver. So what we ask is that just a partial cholecystectomy, and so that the stone just drop off, so it doesn't have a second CVD problem, stone problem. If at all, he recovers completely. Charles, you can just highlight why liver transplant. I didn't follow that.
No, my patient has got an ACLF, 50-year-old with ACLF, MELD score more than 15. So these are patients who are candidates for a liver transplant. The patients with high MELD, high CTP, child BC, they are not candidates for a lap poly because of the risk of the anesthesia.
No, the chances of this patient recovering completely with the stone problem settling down, the sepsis settling down, and he comes back to CTPA, even then, he'll
Yeah,
consider
that's what.
transplant.
If the MEL score is less than 15, yeah, yes, Laponi and follow. If MEL score is more than 15, then it would be a transplant. And this patient with ACLF, how do you grade this ACLF, Samir?
Sir, for ARC4, lactate is not there, but for CLIFC, agent WBC.
How many organ failures are there? Just count the number of organ failures.
Sir, coagulopathy, jaundice, AKI, sir, 3 is coming. Encephalopathy. 3, grade 3 is okay. So
he's got at least three organ failure.
Usually he will maybe he will
support, so we don't know about the oxygen status. So such patients coming out to early B, early A, to child A or early B,
less likely.
Can occur, but then still you will have to start counseling them for a transplant. There are a few questions for you. What are the probable reasons for the others? Right?
What are the probable reasons for worsening after ERCP? Sir, all endoscopic procedures are high risk for cirrhotic patients.
All endoscopic procedures like upper endoscopy?
Sir, even in not a diagnostic, sir, in banding you have to give antibiotic. Interventional therapeutic endoscopy procedures are risk factor for developing sepsis.
Therapeutic procedures are prolonged ones. There is usually some cutting and tissue abrasion involved, and most probably you will be using some sedative or anesthetic agents as well. So, yes, and this is a patient already having problem with infection and other things. So, the sum total of all those things may affect. It is just like a surgery, no?
Yes.
Though even though you are not looking at pakka surgery, it is something short of that. But still, yes, the risks are all fairly same, no?
Yes, sir.
Okay.
Drugs.
So that ECLF, we have already agreed that there is ACLF, and precipitating also, I think we mentioned. Do you think there is a difference between APASL and ESL criteria for ACLF?
Yes, sir. Difference is there, sir. APASL criteria mainly they focus on.
Varghese, just move on. Those typical theory questions and all they answer.
Okay, so please read up this bacterial infection and cirrhosis and annals of hepatology. Okay, the second one is AGA clinical practice update on surgical risk assessment and perioperative management and cirrhosis. You have got some Mayo scoring system, which is online available. This is a Mayo scoring, which will tell you the risk 7 days, 30 days, 90 days, 1 year, 5 years, like that. Okay. So a preoperative assessment has to be done, a post-operative assessment, perioperative and post-operative thing. So a person with cirrhosis undergoing a procedure like surgery, you have to be extremely careful. You have to assess him preoperatively, perioperatively, post-operatively, and it should be a multidisciplinary team to look after, because otherwise you may lose the patient. And if liver transplantation is not thought of, probably cholecystostomy may be done rather than cholecystectomy, which cholecystostomy will be easier and lesser risk compared to cholecystectomy. So thank you, Dr. Samir. And now I invite Dr. Jagdishwar from KIMS for the next case.
Please read about cirrhosis associated immune dysfunction also, CAID. There's something coming up called CAID. Please read about it.
What was it, Dr. Charles? Cirrhosis associated?
Immune dysfunction.
According to ESL Cliff, immune dysfunction is the cause for infection. That is also considered as an organ failure. Jagdish, are you there?
Yes, sir, I'm here, sir.
Okay, please start.
56-year-old male, studied up to 10th standard, farmer by occupation, informant, patient and his wife, history reliable. He is a known case of alcohol use associated with liver disease and treatment from various hospitals for the last 4 years. Present problem, he presented with abdominal distension for the last 1 year, worsened since last 1 month. Pedal edema for the same duration, worsened since 1 month. There is a history of decreased urine output since 2 weeks. Exceptional breathlessness and fatigue since 2 weeks. Mild diffuse pain in the abdomen since 1 week. Sir.
So what do you think? This is a history.
So it's a case of alcoholic liver disease associated with the progressive abdominal distension since 1 year, and it's worsened since 1 month, and associated with history of decreased urine output since
Don't
2 weeks.
repeat it, doctor. Just highlight all the complications. Don't repeat the history. Tell us all the issues. What are the issues? What are the various problems the patient is having?
It's having ascites, ma'am, and one decreased urine output. So probably some hepatorenal syndrome also will be complicated, associated with mild diffuse abdominal pain. So HBP also will be possible, and there is a exertional breathlessness and fatigue, ma'am. So I want to rule out, is there any hepatic hydrothorax or other associated pulmonary complications with the cirrhosis like hepatopulmonary syndrome or portopulmonary hypertension, ma'am.
Okay, proceed.
And then he was diagnosed to have alcohol associated liver disease when he developed jaundice 5 years ago. He had fever for 1 week, abdominal distension, pedal edema at that time. There was no GI bleed or altered sensorium then. He was admitted and treated for 1 month and he improved. He resumed alcohol use after 2 years and was not willing for any treatment or de-addiction therapy. He had some issues with family members regarding his property, which made him resume alcohol use. He used to drink 3 to 5 units, 3 to 4 times weekly. 2 years ago, he sustained multiple body injuries during an accident while riding a bike. According to him, he was not under the influence of alcohol at the time, had multiple wounds which required suturing, no fractures, no transfusions. However, he had withdrawal symptoms while in hospital and had to be treated under psychiatry department since last 2 years. He is not in the habit of using alcohol. He noticed pedal edema and abdominal distension 1 year ago, and he was on treatment with diuretic since then, furosemide and spironolactone. He was not advised salt restriction, but was not compliant.
He was advised actually. That's a typo.
He was admitted 6 months ago due to worsening of abdominal distension, and 3 liters of fluid was removed from the abdomen by tapping. Since then, he had 2 more admissions for tapping ascites. History of removal of
No
larger
history,
quantity
no
of
history.
no history of removal of larger quantity of fluid or albumin incident. Now, for the last 1 month, abdominal distension has worsened along with worsening of pedal edema and diminished urine output for the last 2 weeks. He has been taking medicine regularly. There is no history of NSAIDs or any use of complementary or alternative medication. Now, for the last 2 weeks, he has exertional breathlessness, fatigue, and early satiety, and mild dull aching pain in the abdomen for the last 1 week. No fever or chills. For last 1 week, he has pain mild of left leg at rest, mild increase in movement. There is a gain of 6 kg weight over the last 2 months. So, there is no history of GI bleed or altered sensorium, past illness, no other significant illness, family history, nothing significant, personal history, appetite reduced, sleep disturbed at night, bowels occasionally constipated, bladder habits normal, alcohol used from the age of 30 years, initially once a week, then increased to 3 units, 2 to 3 per week, over a year, increased to 3 to 4 units, stopped 5 years ago and resumed 1 year later. Now stopped completely since last 2 years. No smoking or substance use. Calorie intake requirement in is 1800 kilocalorie. Intake is 900 kilocalorie now. Mixed diet. ECOG performance status 3.
Okay, you summarize.
So this is the 56-year-old male presented with history of alcohol use disorder, probably cirrhosis of liver, uh, followed by abstinence, developed abdominal distension and pedal edema from since last year. It's a recurrent abdominal distension. Um, since last 1 month, abdominal distension is progressive, uh, associated with decreased urine output, and there is a history of pain in the abdomen. And there is no evidence of any history of upper GI bleeding. There is no history of hepatic encephalopathy, and there is no uh,
There is history of repeated paracentesis.
yes, ma'am. History of repeated paracentesis. And he was on diuretics, but not on sodium restricted diet. he was not compliant on diet restriction.
Okay, what is it?
So my my diagnosis will be cirrhosis of liver with secondary to alcohol use disorder, um, uh, portal hypertension with uh, refractory ascites, sir. Associated with complicated refractory ascites, complications by hepatorenal syndrome or SBP.
What
Okay.
are the complications he has? What are the complications? Number one?
Number one is hepatorenal syndrome, ma'am. Number two will be SBP, ma'am.
Any other?
Ma'am, I want to rule out other complications like hepatic hydrothorax also, because he has exertion dyspnea and fatigue or bilateral pleural effusion uh, uh, because of grass ascites, ma'am.
Any
So,
other?
what are the other things you consider when somebody has got ascites which is difficult to manage?
Sorry, sir.
Yes, ascites which has become sort of intractable, no, or rather refractory. So, what are the other causes other than the natural deterioration of the liver function in a cirrhosis and then development of perhaps renal dysfunction? Can you think of any other cause?
Sir, one will be the renal dysfunction only, sir. Renal and any infection secondary to infections like SBP.
SBP, okay, SBP may be a reason for a recent worsening, but
And any new hepatocellular carcinoma.
okay,
Yeah,
hepatocellular
monitor.
carcinoma with
Then, what other complications can occur in HCC?
Hepatocellular carcinoma leads to portal vein thrombosis, acute portal vein thrombosis, tumor.
okay, they can have even
And
hepatic vein thrombosis also, no?
Yes, sir.
Daily, so why did you say refractory ascites?
Sir, sorry, sir. Patient had refractory ascites. He is not completely to the refractory ascites. I can call it as a recurrent ascites for him, sir, more than refractory ascites, because he was not given sufficient dose of diuretic, not given sodium restricted diet, and dose of diuretics also not up maximum dose. So mostly recurrent ascites, then refractory ascites,
I
sir.
can only say probable because we don't have the dose of diuretics. We don't know.
Yes, sir. Yes, sir.
Okay.
On examination, patient is moderately built, weight 68 kg, BMI 24.2, pulse rate 92 beats per minute, BP 140 by 86, alert, poor muscle mass of upper limbs and thighs, frailty test not done, icterus present, spider navy on chest, bilateral gynecomastia seen, no flapping tremor, bilateral pitting pedal edema, more on left side, tenderness on calf muscle of left and more warm, um, Foreman sign negative. Oral cavity, poor oral hygiene, multiple caries, abdomen markedly distended, umbilicus centered, everted, umbilical hernia skin, size 5 cm with thinned out skin, no dilated veins, palpation fluid still present, liver and spleen not palpable, suprajugular reflex absent, drop space dull, no bruit or hum, hernial orifices and external genitalia are normal, parectal examination not done. Respiratory system, no features of pleural effusion, CVS normal, CNS, no overt or occult minimal hepatic encephalopathy.
So, what is it after physical examination?
After physical examination, I want to look for complete hemogram, sir. Look for any thrombocytopenia, anemia, sir, to rule in view of any chance of upper GI bleeding and portal hypertensive gastropathy. I want to see the liver function test. I'll look for AG reversal, any history of jaundice or and AST-ALT levels. Um, then I look for serum creatinine and blood urea nitrogen, sir, and PT INR, serum creatinine, sodium, potassium, and urine spot sodium for 24 hours, and urine uh, And next one is the aesthetic fluid analysis, sir. Aesthetic fluid analysis, I look for sag ratio, and then I look for uh, total protein and albumin levels. And aesthetic fluid analysis for cytology and ADA levels. First time if doing aesthetic fluid analysis for this patient, sir.
Okay, go through the results.
Sir, hemoglobin is 10.2, total count 12,300, sir, and platelet count is 76,000. Fasting blood sugar normal, creatinine 2.1, blood urea nitrogen 77.5, total bilirubin 4.2.
Why don't you interpret each of this?
Yes, sir. There is a thrombocytopenia with leukocyte counts are elevated, sir, with anemia. I want to know the MCV, either microcytic or hypochromic. Even in alcoholics, there will be MCV will be elevated. Next one will be the blood urea nitrogen creatinine elevated. So there is a chance of either acute kidney injury, because I don't know the value of basic value from last 3 months. So either it's a acute kidney injury, difficult to interpret, sir. And LFT, there is a total bilirubin 4.2, and AST-ALT is 64-55, sir. So in alcoholic liver disease, as expected, AST more than ALT, and alkaline phosphatase 186.
It's normal. It's normal.
Yes, sir. AG reversal was 2.2 and 3.2. AG reversal was there. INR is 2.1. Urine protein showed albumin plus and Purcell's 4 to 5 hypophil. And aesthetic fluid total count is 1250. In polynucleoside is 7%. That means it's SBP, sir. More than 250 absolute neutrophil count. And SAG is 1.2. So it will tell us portal hypertension. Aesthetic fluid culture negative, and alpha fetoprotein levels are mildly elevated, sir, 6.9 nanogram per ml. Doppler lower limbs negative for venous thrombosis.
What next?
Sir, next I want to look for ultrasound abdomen, sir. Sunken both lobes, no focal lesion. Portal vein is 14 millimeters. So portal vein is dilated, poor flow detected. Spleen enlarged, spleen vein is 11 millimeters. Splenic hilar collaterals marked ascites. OCD, small esophageal varices with no RCS. Cardiofundal varices, F2, mild PHG.
Okay, so what does it show?
So there is a features of portal hypertension with GRAS ascites, sir. With features of portal hypertension, there is no evidence of any portal vein thrombosis or any focal lesions in the liver.
Jagdish, why did you say there's no evidence of portal vein thrombosis?
They have written poor flow detected.
Did you see the picture before? There is an arrow there.
Yes, sir, arrow there. There is a hypoid.
Yeah, you're not seeing any flow there.
Okay, sir.
You're not seeing any color. What could be the reasons?
Sir, in portal hypertension, the flow will be sluggish or reversal.
Yeah, good. That's one.
But portal vein thrombosis, there will be absence of flow.
You're not seeing any color in the portal vein, right?
Yes, sir. So it will be.
There's partial thrombosis. If there's partial thrombosis.
Can partial thrombosis occur?
Possible, sir. Yes, sir.
The classification wise itself, they say it very clearly, no? There can be flow through portal vein even in presence of partial thrombosis. Okay.
Sir.
That need not be complete. Okay, this particular Doppler didn't show it. What will you do next?
So,
now what? Now with the portal vein thrombosis seen, what all additional things you should keep in your mind?
Sir, in cirrhotic patient, either it is tumor thrombus or non-tumor thrombus, we need to rule out, sir. So next one, I want to do CT liver angiogram, sir, because mildly elevated alpha fetoprotein with GRAS ascites. So it's to detect the focal lesions in the liver will be different. So I want to
Okay.
do the CT
We'll do a CT to detect focal liver lesion like hepatocellular carcinoma. Can you differentiate a blind thrombus and a tumor thrombus?
By Doppler.
In triple
That's a
phase,
standard question. How will you differentiate a blind thrombus from a tumor thrombus of the portal vein?
Portal vein in triple phase angio, there will be the arterial enhancement in thrombus, sir, with wash out in the portal and delayed phases, sir. And
Okay.
usually, portal vein thrombus will continue with the tumor, and it can't be separated from the tumor. And
you get an expansive thrombus.
sir?
You get an expansive thrombus. If you get an expansive thrombus, the size of the portal vein is more than 18 or 20, then you think of a
or rather bulging portal vein. The portal vein bulges with the thrombus. Okay, that indicates it could be a growing or it could be a tumor thrombus. The normal blunt portal vein thrombus is this. The basic size of the portal vein will not increase so much. So that is what Dr. Charles is trying to say. Okay.
The creatinine is 2.1. You want to get a CT?
Yeah, that's what.
No, sir. In this patient, creatinine, no, not possible, sir. CT liver angio.
How do you pick up the tumor then?
Then ultrasound Doppler contrast, ultrasound with contrast ultrasound.
Okay, one is Doppler, ultrasound with the Doppler contrast. Any other method?
What is contrast enhanced ultrasound?
Ultrasound. Sorry, sir, completely.
Just read about what is CES, contrast enhanced ultrasound. You can use sonoview or sonozoid contrast and behave similar to the you get appearances similar to CT or MR on the ultrasound. So you get arterial hyperenhancement, you get washouts.
Yes, sir.
With contrast enhanced ultrasound. Just read about it. So in patients with renal failure and liver masses, contrast enhanced ultrasound might be a better option than a CT.
So patient actually had a CT scan done from the peripheral hospital and then they found a portal vein thrombus and then patient was referred out to us. Okay. So we have not done it ourselves. So this was the finding.
CT abdomen showed cirrhotic liver, no focal lesion, gallbladder normally distended, hepatic veins normal, portal vein showed a thrombus extending to the proximal superior mesenteric vein, no contrast enhancement, multiple pollators around the portal vein, splenic vein patent, multiple pollators near the splenic hilum, moderate splenomegaly, significant ascites noted, pancreas normal, stomach and small large bowels appears normal.
Okay. So same finding. There is no HCC and there is no contrast enhancement. So it looks like, so this is a blind and therefore we will not think of HCC at all.
Yes, sir.
There is no HCC seen as per the CT. Okay. But I also doubt whether it was done under the HCC protocol. That's another problem. Most of the peripheral hospitals, because they have got the CT scan and all, they will ask for the CT scan and they won't ask for the HCC protocol. So the protocol will not be followed and one may even miss it. Okay, or atypical findings may be there. So if it is not done under a protocol, you may have to repeat it, but we have to wait for the creatinine to become normal. Otherwise, we won't be able to do. Okay, how will you proceed further?
Sir, then I want to then I want to start this patient, stabilize the patient with, I'll start IV antibiotics and I'll send the culture, ascitic fluid culture. In this patient, it came no growth, sir. Broad spectrum IV antibiotics, probably cephalosporin sulbactam to cover wide spectrum or cefotaxime, I'll start, sir. And next one, I'll start him start him on sodium restricted diet up to 80 milligrams per day, 80 to 90 milligrams. and nutrition and albumin infusion, sir, 8 milligram per deciliter. So, and I'll monitor the urine output, strict urine output.
How much of albumin did you say? I did not get you.
Sir, albumin per day 100 milligrams, 100 grams per day, sir.
How did you get that figure? 100 grams per day? How do you give albumin? How do you give albumin?
Ma'am, albumin is by infusion,
What
ma'am.
are you trying?
Usually
What are you trying to treat here?
to replace.
What is your diagnosis? Is it HRS? No, non-HRS AK.
Sir, it's HRS AK.
HRS AK. So what is the
Because
HRS AK?
yes,
How do you treat HRS AK?
HRS AK, I'll treat with there is a part of sepsis also, sir. In the patient, there is a SBP, and treat with.
How do you treat HRS AK? Question is simple.
Yes, sir. HRS AK first will be the volume replacement with albumin. First, then I'll with then terlipressin I'll give, sir, 3 milligram, 3 milligram over 24 hours.
So HRS AK treated with vasopressors and albumin. And what is the dose of albumin?
Albumin is usually 1 gram per kg up to 100 grams per day. We can maximum we can replace it.
Okay. On day one, 1 gram per kg up to 100 milligram, and then 20 to 40 grams per day.
Yes, sir.
And what vasoconstrictors do you use?
Terlipressin, sir. Terlipressin 3 milligram per 24 hours, like infusion doses. So I'll mix it 3 ml of 3 ml of terlipressin in 50 ml of normal saline over 24 hours. Infusion will give.
Okay, what are the other options? Suppose terlipressin is not available or patient is not tolerating terlipressin.
Terlipressin is not available, then norepinephrine I'll start, sir.
Any other option? Do you use octreotide?
Yes, sir. Octreotide also, yes, sir.
Okay. So here we have got a patient with cirrhosis. It's got decompensation, SBP, AKI. It's started him on antibiotic, vasopressin, and albumin.
Albumin and nutrition, with a decompensated cirrhosis, I would like to give 35 to 40 kilocalories per kg per day, sir. With because of renal failure, I'll restrict the protein intake to 1 gram per kg per day. And with nutrition and anti-hepatic encephalopathy measures, then
He has no encephalopathy.
clinically there is no encephalopathy, ma'am, but because of these patients is more prone to there is a SBP and recurrent ascites, so there will be all translocation. So like to give anti-encephalopathy.
Okay, Dr. Charles. Any further?
Do you use anti-precoma regime as primary prophylaxis in a patient who doesn't have hepatic encephalopathy?
Primary prophylaxis. Non-bleeder.
Is it required? Yes or no?
Sir, yes, sir.
No. That's what I feel.
Prophylaxis.
Okay.
Don't think there's any evidence as of now. We can, in patients with hepatic encephalopathy, you can treat, and you can use it to prevent recurrence. Okay. Otherwise, I don't think there's evidence for a primary prophylaxis.
Okay, read up LVP, role of albumin and indication in various conditions, tips in such situation.
Can we transplant? Let him answer that question. Dr. Charles is around, so let him listen.
Okay.
Just
So,
take up a few questions on transplant.
what about transplantation in him? Or will you manage it conservatively?
Sir, because the MELD score not involves SITs as a score for this thing, and but creatine will be, so his MELD score will be more than 20, sir. So,
You're going into deep trouble there.
sir,
I think your answer is not
The patient
correct.
require transplant or not?
yes, sir, he requires transplant.
Is he a candidate for tips first? Okay, let's see. How do you manage refractory ascites? What are the treatment options?
Sodium restricted diet, sir. Refractory ascites, large volume parasitosis,
Tips,
tips,
tips
and
tips and
then final option will be the transplantation, sir.
okay. What is alpha pump?
Alpha pump is ascitic low flow pump.
Where do you use alpha pump?
Sir, alpha pump in refractory ascites, but there is with the alpha pump there is a chance of getting a recurrent acute kidney injury and local site infections. So only European countries mostly using this alpha pump.
The patients who are on palliative care, patients with refractory ascites who are not candidate for tips or liver transplant. Such patients, alpha pump is an option.
Okay.
So you don't have to bring them in for repeated taps and albums.
Okay, sir.
And is he candidate for tips?
Sir, depends upon if MELD score will be more than 18 and bilirubin will be more than 3. So usually if MELD score more than 3, MELD score more than 18 and CTP score more than 12, bilirubin more than 3 will be not a candidate for tips, sir.
Okay. And what about transplantation?
Yes, sir. We need to list for the transplantation, sir, because
It's got bilirubin of 4.6, INR is 2.1, VAT is 2.1. What would be his MELD score? A rough approximate.
MELD score will be more than 25, more than.
Okay, suppose his MELD score is more than is 14. He has got refractory ascites. He's not a candidate for tips. Would you consider transplant?
Yes, sir.
So that brings the question: what are the MELD exceptions? There are a few MELD exceptions, and you should know what are the MELD exceptions.
Sir, MELD exceptions will be hepatopulmonary syndrome, sir, hepatic hydrothorax, and hepatocellular carcinoma.
Okay, HCC, some centers give MELD exceptions. So the other complications of cirrhosis that are not reflected in the MELD, if they are causing significant reduction in the quality of life, so you can give MELD exception points. The patient with refractory ascites requiring recurrent taps, even if the MELD is below 15, then you can consider liver transplant there.
Okay, sir.
Okay, I think there's nothing more to add. Is there a role for midodrine, Vaptan in this case? Dr. Charles can answer. Jagdish, do you think there is a role for midodrine or Vaptans?
Sir, midodrine, there is a role, sir, it's an alpha-1 adrenergic agonist in refractory ascites. But Vaptans, there is no role, sir. And there
What's
will be
the role of midodrine here?
midodrine causes vasoconstriction, sir.
Mm-hmm. So
And increase the natriuresis and
so octreotide plus midodrine and albumin in type 1 HRS, because terlipressin is not available in the US, so they use more of octreotide, midodrine, and albumin.
yes, sir.
Okay, that's one indication.
Okay, sir.
Otherwise, there are no strong recommendations to use midodrine refractory ascites. Even though we use a lot, there's no strong evidence to use it. Please read up the MASH trial, the trial of metodrin plus albumin in refractory cirrhosis and ascites.
Answers. The question is SBP a MELD exception?
SBP is not a MELD exception, madam.
And treatment of portal vein thrombosis in this case actually is chronic, no? So is there any role for anticoagulant?
Okay. There is you want to take that? Or?
Sir, ma'am, there is no, there is a portal cavernoma, ma'am, and chronic portal vein thrombosis in cirrhosis patients, there is no role of anticoagulation, ma'am.
Where did you say portal cavernoma?
Nothing to
Sir,
collaterals are there.
sorry, collateral, sir, not portal cavernoma, sorry. Collateral surgery.
Gland thrombus, right?
Yes, sir.
Is there any indication for anticoagulation here?
No, sir. No, in this patient, no indication, sir.
Suppose the patient is a candidate for liver transplant. Okay,
Yes,
that you don't want the thrombus to progress into SME or into the deep into the SME, because in such situation, patients who's got thrombus who are candidates for liver transplant or on waiting list, we tend to anticoagulate them because we don't want the thrombus to be progressing.
I think this patient already had a thrombus extending into the SMB.
Yeah.
As
We
per
don't want it further progression. So if the candidate for liver transplant, definitely yes, we will anticoagulate them.
And the extension to SMB, I think we must consider serious issue because further extension will create a lot of problems. So I think that is an indication for treatment. Extension to SMB, even the proximal SMB is an indication for treatment.
But will these chronic thrombus resolve with anticoagulants?
But I think except
can you prevent extension, but may not.
Yeah.
If I'm right, I'm not certain about it, Dr. Charles.
This chronic thrombus won't resolve, ma'am. It won't resolve. We're not giving for it to resolve.
Only to prevent further extension. Okay.
If it extends into the SMV, then you may not get an inflow at the time of transplant. It may be difficult to get an inflow. So, such situation we may have to do transposition, and so that's the only indication for anticoagulation.
Thank you, Dr. Charles, for giving us a lot of information. And I think both the candidates did quite well today. What's your assessment, Dr. Charles?
Yeah, both of them did very well, ma'am. Nice. Thank you.
Okay, I think these are the areas, some areas which requires a little more reading. Infection in cirrhosis, especially various types and different types of infection, antibiotic use, empirical management and subsequent management according to culture report. Then this portal vein thrombosis, these are usually not discussed. So just read up. You have a lot of papers on these things. Okay, I think we should stop today. Any question from anyone's side? No, I think. Can we close the session?
Most of the chat box questions have been answered, I think. So
I have not looked at the chat box. Is there any questions there, ma'am?
Nothing specific. Most of them I get answered.
Okay. So we will, I will thank you both the residents.
One question, Dr. Charles. Is there, if there's multiple organ failure, is there a indication for liver transplant?
Yeah, I just answered that in the chat box.
You answered.
Okay. I'll just explain. The lung involvement is the most dreaded one. That has got very high mortality post-transplant. And when there is multiple organ involvement, whether to transplant or not depends on the extent of involvement. If the multiple inotropic supports, suppose the patient is on 3 inotropic supports, if it's on high FiO2, then such patients we may not. But if we have got some area to maneuver, it's only on one support, FiO2 is not high, like it's on ventilation for protecting the airway because of encephalopathy, it's only on one support. Such patients we will consider for a transplant. But patients with multiple supports, high FiO2 of more than 60, then such patients we don't consider for a transplant.
More than 2 organs, they say, no? More than 2. Up to 2, I think. And the type of organ.
Okay, we will wind up today. Thank you, Dr. Charles. Thank you, Jayanti ma'am. Thank you, the residents, for joining us for discussion. The next session is on 13th. Professor Vinay Kumar we'll be discussing again on cirrhosis, some other aspect, maybe GA bleed and other things. Okay, with Dr. Ramesh. Until then, goodbye. Good night to all of you.
Good night. Thank you. Thank you.
Good night. Thanks, Dr. Charles.